So, uh, good evening, everyone. So, I am really thankful to Clarnet for giving me this opportunity to present this important topic, that is principles of clinical pharmacology in optimizing diabetes management. So, I am Dr. Shambho Samazdar. I am now attached with School of Tropical Medicine as a clinical pharmacologist, and also I am attached with a therapeutic super specialist at Allergy Asthma Treatment Center and Diabetes Allergy Asthma Therapeutic Specialty Clinic. So with that, in this diagram, we can see what is clinical pharmacology. Because as today we are going to discuss about clinical pharmacology principles in diabetes management, we need to know what is actually clinical pharmacology. So it is nothing but the science which tells us the story of relationship between drugs and humans. So there are different aspects of clinical pharmacology. As we are talking about diabetes management, we know every day new drugs are coming up. So drug development itself a separate uh, subject. We are not going to focus on that area because that deals with multiple separate things. We today are going to discuss about how we can have a balanced prescribing. So how the principles of clinical pharmacology, the knowledge of pharmacokinetics and pharmacodynamics, and then translating it to practical drug therapy, clinical toxicology, understanding, monitoring of individual patient, and also to understand, to anticipate the adverse drug reactions or adverse drug-drug interactions that we are going to discuss today, and how the evidence-based medicine tells us to prescribe safely, that we are going to discuss. So clinical pharmacology is the science which tells us the relationship between drugs and humans. And we all know that prescriber and patient, they are connected by prescription, which is done, is known as prescribing, and that is a very risky behavior. We all should appreciate that it is a risky behavior. And what is the goal of rational therapeutics? To balance, to have a perfect balance between benefits of prescribing and also the risk of prescribing. So this balance is very important. Why it is important? Because if we just check 50 most popular drugs, then average number of considerations for single drug are enormous. So adverse drug reactions per prescribed drug, it could be at around 40. Contraindications per prescribed drugs, it could be at around 32. There could be a 76 on an average drug-drug interactions, drug-drug adverse interactions per prescribed drug. There could be some specific demographic considerations, may up to 2 to 10 per prescribed drugs. So this is why we need to know what is balanced prescribing, and for that the clinical pharmacology reconciliation, this principle of reconciliation is extremely important. And what are that main points? Number one, we should prescribe any drug with a clear therapeutic goal and evidence base for each prescribed drug. So there should be a valid clinical indication. And for that, we need to give stress on patient-oriented evidences. So actually, POEMs means patient-oriented evidence that matters compared to disease-oriented evidences. So patient-oriented evidences, and that is also known as personalized medicine, precision medicines. One of the goal is personalized medicine. And for that, the first principle of clinical pharmacology reconciliation is to check whether I am prescribing a drug with a valid clinical indication. Next important point is pharmacokinetic and pharmacodynamic rationale behind my prescription. Third is whether I am prescribing in a right dosage regimen. Fourth issue is to address polypharmacy, because again, what is polypharmacy and what we actually want for one ambulatory patient to treat one disease, our goal should be we should treat that particular patient with not more than 2 medicines. So if it is more than 2 medicines, so that is a challenge. Sometimes polypharmacy is also rational. I'm not going in that part, because in disease like antitubercular, if we are using antitubercular drugs for tuberculosis patient or HIV patient, there is a legitimate need of polypharmacy. But general dictum is for one ambulatory patient to treat one disease, our goal should be not giving more than 2 medicine. And why polypharmacy is important specifically while treating diseases like diabetes or any other chronic disease, giving emphasis on adherence, because if the number of drug increasing, then what happened? There will be non-adherence. The issues of non-adherence will appear. And obviously the patient safety issues like adverse drug reactions, adverse drug-drug interactions need to be given importance. What is the adverse impact on quality of life? That again need to give stress. And there are lots of medication errors. And one of the most common medication errors that happen in chronic disease care at the time of transition. So transition of care related issue need to be given emphasized. And if it can be, the transition could be from home to hospital admission, that means emergency room, from emergency room to either critical care unit or daycare bed or any general bed, general patient bed, or it could be from critical care unit when going down, stepping down the therapy to the HDU or to the general bed. So, and even at the time of discharge, what happened if we not go through the principles of this clinical pharmacology reconciliation? There may be a possibility that some drugs which was previously prescribed before admission would be missed while writing the discharge note. So everything need to be checked, and thoroughly we need to go through this concept of clinical pharmacology reconciliation while discharging our patient. And there are few important principles of clinical pharmacology care. Number one, to treat adverse drug reactions. So it is important to identify and promptly treating adverse drug reactions, because otherwise it will produce a prescribing cascade. We need to avoid prescribing cascade. And the mantra should be start low, go slow, but obviously we have to go. Special interventions are required in specific cases like renal and hepatic compromised patient. We need to consider deprescribing. What is deprescribing? Means stop any drug without known benefit and discontinue a drug with actual or potential adverse effects. So it also includes substitution within class, because that also can eliminate adverse drug interactions and adverse drug reactions. So most common examples are if we use some drugs like maybe statins. So from atorvastatin to rosuvastatin. So there are chance of adverse drug interactions with some specific molecules. Or if in a same class, some pedal swelling happening to amlodipine, we may try to deprescribe that amlodipine and we can switch to another drug, substitute to another drug, which have a less potential to produce pedal swelling. So these are the main principles of clinical pharmacology care. Now coming to principles of clinical pharmacology, which play a critical role to optimize diabetes care by critically considering two things. What are the two things? Number one, there are some patient-related factors, and number two is some precision therapeutics. So there are some therapeutics related factors that we need to consider. What are the patient factors? Lifestyle history. Before jumping to prescribe any drug, it is our responsibility to understand the lifestyle of the patient. Need to assess the comorbidities. It could be atherosclerotic cardiovascular disease, chronic kidney disease, heart failure, but we need to understand that comorbidities. Then there are some important clinical features. The characteristics of the patient, age, BMI, HbA1c level, that will tell us what to choose and what not to choose. The psychological status, the motivational level of the patient or depression, because that should be addressed, because this psychological status is directly proportional to adherence related issues. So depressed patients will have most commonly they will face the non-adherence and other cultural and socio-economic issues. Very important, specifically when considering drugs in countries like us, where cost is a very important factor. What are the precision therapeutics? That means how we can go to choose accurate therapeutics. It is, by definition, we all know that anything accurate, it is very difficult to get. But our target should be to reach the accuracy, to have the accuracy. So that is why the concept of precision therapeutics came. So first of all, we need to individualize HbA1c target. So how we can individualize HbA1c target, that is again a separate chapter, but it is, we all should appreciate that if a patient of 35 years came to your OPD and it is he has no other comorbidities and no other illnesses, so your target should be, the HbA1c should be less than 6.5%. But if a patient with the age of maybe 60 years, chronic kidney disease patient, and already the creatinine is high, duration of diabetes is maybe 15 years, 20 years, like that. In that case, the HbA1c target could be little bit relaxed. It could be between 7 to 8%, like that. The first goal should be, we need to prevent hypoglycemia in this type of case, and we can little bit make the HbA1c target upward or relaxed. If a patient came to your OPD with a pancreatic cancer and the life expectancy is not much, maybe 6 months, like that. So even if in this type of patient, the HbA1c of 10%, 11% could be acceptable. So only you have to give the therapy to control the symptoms of hyperglycemia. Otherwise, there is no need to have a stringent control in this type of patient. So individualization of HbA1c target is very important, and that is the first mantra to have the accurate therapeutics. Next part, we need to choose drug considering its impact on body weight and also its potential to produce hypoglycemia. Adverse effect profile of a drug. We need to consider the complexity of regimen, frequency, mode of administration. Specifically, this is important for in those patients where we are going to start insulin. Optimization of the adherence, because if a patient is not taking a medicine, that means it will not, the medicine is not going to work anymore. So first thing, to have a to start a therapy, our goal should be the patient should take the medicine, should adhere to the therapy. Access, cost, and availability of the medicine. These are again an important part to reach the accuracy in therapeutics. And for that, I think we all know this guideline, ADA 2022. So everything in this guideline that tells us how we should consider the patient-related factors and also some therapeutics-related factors to reach to the correct therapy. So first line therapy, yes, that depends on comorbidities, patient-centered treatment factors that includes cost and access, availability considerations, and management needs. Generally includes, so this is important to note. Initially, it was told that metformin only, but this terminology generally is very important because maybe some patient will come to us, they require SGLT2 inhibitor as a first line drug or GLP-1RA as a first line drug. That could be possible, but generally it includes metformin and comprehensive lifestyle modification. Then we need to check whether the patient has comorbidities like atherosclerotic cardiovascular disease or indicators of high risk for atherosclerotic cardiovascular disease, or patient have heart failure or chronic kidney disease. Then we should choose the drugs. Like in case of atherosclerotic cardiovascular disease or high risk for this ASCVD, then either we can choose GLP-1RA or SGLT2 inhibitor. In presence of heart failure, the first line therapy should be SGLT2 inhibitor. The CKD case, again, we need to check that CKD albuminuria, CKD without albuminuria. So preferably SGLT2 inhibitors after this DAPA CKD trial and some also in Credence or in case of Emperor reduced, also we will get some data. So what happened, the SGLT2 inhibitors, they have the primary evidence of reducing this chronic kidney disease progression. So we need to choose that CKD patient. And also there are some data that coming up. Specifically, we all know the data of dulaglutide, where the GLP-1RA they have a proven CVD benefit. Also, there is some benefits in terms of kidney outcome. But of course, in first line, if we just say in presence of CKD, it is SGLT2 inhibitor. Now coming to other. So those patients who does not have this type of characteristics of atherosclerotic cardiovascular disease, heart failure, or CKD, then we need to consider some other issues. Again, the first one column could be where we want to minimize hypoglycemia. Then there are some choices like DPP4 inhibitors, GLP-1RA, SGLT2 inhibitors, or thiazolidinediones also like pioglitazone. When we want to promote weight loss or minimize weight gain, then GLP-1RA with a good efficacy, they have a good option. They are a good option. All the SGLT2 inhibitors also. And also, when we need to consider cost, access, and availability, there is the role of certain insulins that is available in the country as a lowest acquisition cost, or sulfonylurea or thiazolidinediones. But in India, we are fortunate that our DPP4 inhibitors are also very cheap now. And also, very recently, we know the dapagliflozin, which becomes, there are lots of generic drugs are coming with this dapagliflozin, and we can say this is a cheap molecule, cheap SGLT2 inhibitors also. So this is a beautiful diagram, beautiful flowchart, which emphasizes the how we should go to prescribe an anti-diabetes medication with to a T2DM patient. How we should consider some patient-related factors and some therapeutics-related factors together to prescribe one drug. So I am not going in details of this. Already we had discussed. I will jump to one real-life case that we had faced. A 68-year-old Mrs. AJ. She had presented with severe weakness for 5 days. She has osteoarthritis, both knee, hypertension, type 2 diabetes. So last 5 months, she had pedal swelling and also severe pain in both knee joints. So BMI is 36 kg per meter square. Now you can see the list of current medications she was taking. And apart from this medication, sometimes for this pain, some physicians prescribed this fixed dose combination of trypsin, bromelain, diclofenac for maybe twice daily for 5 days. But what she is doing now to get relief from the pain, she is taking this fixed dose combination occasionally, intermittently. And for pedal swelling, it was decreased with a furosemide 40 milligram tablets for last 7 days. So for pedal swelling, she is taking a furosemide tablet for last 7 days. Now, what are the lab results for her? The HbA1c is 8.6%. You can see the hyponatremia, also hypokalemia. Creatinine is 1.4, so eGFR is 41.9. All other routine tests normal. So what is important? First thing we need to go through this patient is the pill burden. So many drugs the patient was taking. So patient has one complaint with a severe weakness. So we can now appreciate that the reason for this severe weakness is hyponatremia. And why hyponatremia had developed? Because of that furosemide 40 milligram tablet. Now, if we just think why the patient require furosemide tablet, because the patient has a pedal swelling for 5 months. Now just go through this pill burden and you can appreciate what are the reasons for this pedal swelling. The patient is taking pioglitazone, patient is taking amlodipine, patient is taking pregabalin. Apart from that, you can see the eGFR value is low, and it could be due to that intermittent use of diclofenac combining fixed dose combinations. So she's taking that intermittently. So that diclofenac induced kidney insult, that may be a reason of this type of pedal swelling. And we also know that eGFR was low. So without going through the root cause of the disease, just symptomatically treatment may worsen the condition. So patient may have a knee joint pain. So she was taking that diclofenac, and that causes some kidney compromise. And also there are some drugs which is responsible for pedal swelling. So the combined effect that happened, what happened? There is pedal swelling, and for pedal swelling, the patient took one furosemide tablet, and that furosemide tablet causes hyponatremia. So now you can see this is called as prescribing cascade. The ongoing cycle of adverse drug reactions is going on and on. So we need to identify the culprit molecule first, and we need to deprescribe that. So what the reconciliation was done, the initial, all those drugs, you can see the patient was taking metformin 2 gram when her EGFR was below 45. So we need to half the dose of metformin, and we need to stop all the ongoing anti-diabetes agent. The patient's BMI, we need the patient related factors need to be given emphasis, and for that the BMI was 36, quite high. And with that type of BMI, if without addressing the body weight, if we just try to treat osteoarthritis, it will not give any relief. And the patient was taking some drugs which actually increase the body weight, like glimepiride, like pioglitazone. So these issues need to be addressed. And for that, what happened? All the anti-diabetes drugs were stopped. The dulaglutide was introduced along with metformin 1 gram. Initially 2 weeks, there was the patient was weak and patient has hyponatremia. So initially the patient was stabilized with basal insulin, but dapagliflozin was initiated after 2 to 3 weeks, 10 milligram once daily. And for pain, only paracetamol 1 gram was given twice daily as OS basis. Atorvastatin dose was step up, 20 milligram, aspirin 75 milligram. It was initially rosuvastatin, as there is some kidney compromise. So it is better to give atorvastatin. We all know why it is important. Need to stop the amlodipine because of that, to check whether the pedal swelling is also contributed by this amlodipine or not. Telmisartan 80 milligram was initiated. The lifestyle modification, physiotherapy, these all were advocated, and also the follow-up to orthopedic surgeon was also advised. Another important steps that was done here, you can see in the pill list, the calcium carbonate and vitamin D3 combination was prescribed. So we all know when we are giving some PPI and our pH will be increased. So increased pH means there will be less absorption of calcium if we are providing it via carbonate salt. So we need to change the salt. So here, what after reconciliation, we prescribe it as calcium citrate plus vitamin D3. So results after 6 months, the BMI was quite decreased, 28, pain decreased, no pedal swelling, creatinine level was 1.2, so EGFR improved, and also the HbA1c better. So this happened due to this timely deprescribing the culprit drugs, and to stop the prescribing cascade, and to address the patient holistically, to consider her post-related important issues like body weight and also the compromised kidney functions like that, along with some drugs related factors targeting the HbA1c, and some what are the drugs that could be could cause adverse drug interactions or adverse drug reactions. We need to deprescribe those drugs, and we need to add the right drug at right moment. So this is why the prescribing cascade, addressing the prescribing cascade is very important. And this case was published in JAPI very recently by us. And actually, there are 2 to 3 more other cases also. It was a case series. So why we are giving stress on this issue? Because this type of clinical pharmacological principles, if we use in our patient care, that can obviously optimize our patient care. So also we need to address these medication related problems, and then we should also propose what should be the interventions. So first of all, we need to understand these medication related problems. That means any aspect of patient's drug therapy that is interfering with a desired positive outcome or endpoint. And here also, again, I want to re-emphasize that outcome means the patient-oriented outcomes. So this is very important. So whether there is a no indication for current drug, indication for a drug, but non-prescribed. So there is an indication for a drug for this particular patient, but it was not prescribed. Wrong drug regimen prescribed, where more efficacious choice is possible. Too much of the correct drug or too little of the correct drug. There is a adverse drug reaction or drug allergy that happening, but we are missing that. Drug disease, drug food interactions. Patient not receiving a prescribed drug, adherence related issues. Sometimes the routine monitoring, if it is missing, then that also denoted as medication related problems. And it could be some overlapping adverse drug effects or other problems like that. So medication related problems we need to understand, and clinical pharmacology principles help us to understand these medication related problems. Now coming to another part of this presentation, that is whether the presence of diabetes may alters the pharmacokinetics of other drugs, other non-diabetes drugs. So we all know that PK means the absorption, distribution, biotransformation or metabolism, and elimination. So in each step, in presence of diabetes, there is a possibility of change in these PK parameters. So while we are prescribing other drugs to treat other comorbid disease, we need to be very cautious. And here I must confess that there are lots of new drugs are coming up, but we don't have that much data with those drugs, how their pharmacokinetic parameters actually present in diabetic patients. So this is an area which need further research. So absorption could be altered due to changes in subcutaneous adipose blood flow, muscle blood flow, and gastric emptying. Distribution due to non-enzymatic glycation of albumin, because that is also a possibility in case of in diabetes patient. The biotransformation, because there are some enzymes and transporters changed due to presence of diabetes, and as there is a possibility of nephropathy or even the metabolic disease associated liver injury. That is a very common entity now, the NASH. So we all know that if we see 100 of diabetes patients, it could be at around 20 or 30 patients whose SGPT, SGOT, and other liver functions may be altered. So this altered liver and kidney function may lead to change in the elimination of the drugs, and that also we need to understand. There are some old data, old studies, beautiful studies done in JIPMAR by Dr. Adityan and other great clinical pharmacologists, which had suggest this, that presence of diabetes could alter the pharmacokinetic characteristics of particular other non-diabetes agent. And that is why it is our duty, whatever new drugs are coming today, what are the new non-diabetes drugs are coming today, maybe an antihypertensive agent, maybe a statin, we need, or some immunosuppression drug, we need to check their pharmacokinetic property in diabetes individual also. How those drugs behave with diabetic individual, that we need to understand. Or rather we can say the opposite word, because as we are talking about the pharmacokinetics, how a diabetic subject is behaving with that other anti-diabetes agent, that is very important, and that need to be explored. Not only the pharmacokinetics change, the pharmacodynamic parameters also changed in diabetic. So it has been seen that the rifampicin concentrations were universally low in diabetic, non-diabetic patients, but the concentrations of isoniazid and pyrazinamide were reduced in patients with diabetes mellitus. And the important issue is that in patients with diabetes mellitus, the time to culture conversion was positively associated with isoniazid and rifampicin concentrations. And actually, they are negatively associated with pyrazinamide level. So even if the pyrazinamide concentration increased to match that pharmacokinetic property, with there is no extra benefit that is got by elevating that pyrazinamide level. So there could be a possibility of decreased pharmacodynamics of pyrazinamide, and that is generally happened. The mechanism is like that. Propose that xanthine oxidase, which is with a strong association between HbA1c values and oxidative indices. So pyrazinamide induced oxidative stress could be a possibility of this type of pharmacodynamic failure in diabetic patient. Now, another important issue is CYP3A4. We all know there are lots of drugs which is metabolized by CYP3A4, and significantly reduction in the expression of CYP3A4 in diabetes patient, and that is very crucial to consider, because CYP3 generally CYP450 enzymes metabolize approximately 60% of the prescribed drugs. And if we just consider the CYP3A4, they are responsible for about half of this metabolism. So almost 30% of the drug is metabolized by this CYP3A4. It could be acetaminophen, codeine, cyclosporine, diazepam, erythromycin, lots of drugs. So as the CYP3A4 activity is reduced in diabetes, so what happened? There could be a more chance of toxicity. So we need to be cautious. Apart from that, the CYP3A4 also metabolizes some steroids and carcinogens. And we all know that diabetes patients, they have more chance to develop cancer compared to non-diabetic individual. It could be one of the reasons, because CYP3A4 activity is diminished in diabetic patient. It could be a reason behind that also. They are less metabolizing those carcinogens. Another important aspect, how to rationalizing the design of dosing regimens. There are some general principles. This is important. Why? because many of our diabetic patients will develop kidney disease. So we need to have a therapeutic target, choosing the initial dose of the drug, then maintenance dose, dose frequency, and when a dose adjustment should be performed. So it is always important when we are talking about some chronic disease like diabetes, start low and go slow approach, because we don't need to have a hurry in this type of patients to reach the target. Yes, in case of ICU admitted sepsis patient, we need to give the antibiotics in full dose, because inappropriately dosed antibiotics will not going to help our patient. So that time the loading dose concept is very important. But for this case, to manage diabetes, to target HbA1c, we should not have any hurry. And this we can see here the same dose. This is a pharmacokinetic study done with metformin. So in the blue line, you can see the 2000 milligram alternate day dosing. In red line, you can see the 1000 milligram once daily dosing. And in the green line, you can see the 500 milligram twice daily dosing. So what happened after 72 hours, they reach the maintenance dose or a plateau concentration. But if we just check the proposed target concentration, then you will find the 2000 milligram alternate days dose, so much fluctuation is there, and also the 1000 milligram once daily dose, there is so much fluctuation. So this is why we need to understand the maintenance dose concept, because a decrease in drug clearance with kidney disease prompts a decrease in either the maintenance dose or an increase in the dosing interval. From this formula, we can well appreciate this concept. And this is what clinical pharmacological principles teaches us to modify our medication regimen. So dose adjustment in patients with chronic kidney disease are based on the change in the concentration time profile for the drug of interest. So here, if we just take one examples from repaglinide, which is where the substrate of CYP3A4, CYP2C8 and other enzymes in patients with advanced chronic kidney disease, the mean area under curve increased by 232% and Cmax increased by 82%. So compared to the patients who have no kidney disease. So how we can achieve the plasma concentration similar to those in patients without kidney disease? In here, we need to consider both the dosing interval should be prolonged and a lower dose should be prescribed. So this should be our mantra in case of diabetic kidney disease patient. Another important aspect when we are talking about clinical pharmacology, to check the chronopharmacology, to check the circadian system. So any metabolic syndrome, any metabolic disease, the cause is the desynchronized circadian system, and it could be due to shift work, night eating, breakfast skipping, sleep restriction, sleep fragmentation, high fat diet, everything is contributing. So our behavior level is changed, and that causes a disruption in the synchrony of the circadian rhythm. And you can see how the normal physiologic insulin secretion changed to diabetic insulin secretion. And ultimately, this change also happened at the molecular level. The clock gene, the clock which is clock control gene, that is totally changed. And ultimately, the metabolic outputs, the signals altered, and there will be a circadian dysrhythmia. So from normal leptin level, normal insulin glucagon synergistic insulin glucagon relationship, GLUT2 level, what happened due to this circadian arrhythmia or circadian system disruption is there will be an increased leptin, decreased insulin, increased glucagon, and GLUT2 receptor will be decreased. And there is a thought that also seen our melatonin level also decreased. So this is why the light has an effect, the sunlight has an effect, and our reaction to light, if change happen to that, our reaction becomes altered, then we are definitely going to face this metabolic insult. So this is again another important issue. Now coming to the last part of my presentation, pharmacogenetics in precision medicine, or choosing the accurate medicine for type 2 diabetes. Though this is a developing part, we don't have that much data or that much possibility to practice this pharmacogenetics in real life, but these are evolving concepts. Number one, metformin. So it has been seen that better response with reduced GLUT2 transport, and if there is a altered or reduced OCT1 transport, then there will be more metformin related side effects, GI effect, or PMAT expression, ACRT genotype, if it is reduced, so there will be more side effects. In case of thiazolidinediones, the response and weight gain with rosiglitazone altered by CYP2CA8 and SLCO1B1 activity up to 0.7% of the HbA1c level. Sulfonylurea, they are 3.44 times better in those who metabolize sulfonylurea slowly. That means who has CYP2C9 polymorphism, and it could produce a difference in HbA1c reduction up to 0.5% also. If there is a variation in that particular gene of CTRB12, there could be a 0.5% difference in HbA1c reduction. So a time will come, we will check certain genes is present in one person or not, and we can decide that this medicine will produce side effect, or this medicine is going to produce better HbA1c reduction. So this is the concept. And even the costly drugs like GLP-1RA, there is one locus of CTRB12. If it is effect, it could be, if it is changed, there is some change that can cause a different effect to GLP-1RAs. So pharmacogenetics reveals that certain genes are associated with therapeutic responses. In this slide, you can see different genes which were explored by different scientists to, and it has been associated with different types of anti-diabetes agents effect. SGLT2 inhibitors, SLC5A2 gene, for GLP-1RA, there are lots of genes like already we had discussed, and this TCF7L2 is very important. These variants are also reported to play a role in response to GLP-1RA. And also that TCFL2, DPP4, and PNPLA3 have been associated with DPP4 inhibitor response. So what is, this is a futuristic picture diagram. How we may use pharmacogenetics in future diabetes clinic, that a person with diabetes treated with metformin with HbA1c of 8% enters into your clinic. A second line, another oral anti-diabetes agent you want to start with. So for that, you need some clinical decision support tool. Yes, the patient related factors like age, sex, BMI, waist, ethnic group, fasting insulin value, which could tell us the level of insulin resistance in that particular patient, lipids, and then the genotype and some specific biomarker panel, if we can develop, that will give us answers like that, whether if we just add sitagliptin to this particular patient, then likelihood of response is 88% and likelihood of ADR is 2%. So this thing we need to evolve, we need to do more research in this area, and also we need more financial support in this type of researches. So with that, I want to again thank you all. And because I am talking about clinical pharmacology, optimization, and diabetes, so I must sincerely pranam my two gurus, Professor Shashankar Joshi, my guru in the field of diabetology, and my professor, head, mentor, Professor Shantanu Kumar Tripathi, who is my mentor and guide in the field of clinical pharmacology. I just want to pray to Almighty that I am really thankful to Almighty for providing me these two excellent gurus, and because they actually help me to understand this subject a little better format. So Agyanat Timirandhasya Gyananjana Shalakaya Chaksurun Militang Jena Tasmai Se Gurave Nama. Once again, I thank Clarinet for giving me this opportunity to present this important topic in front of you all. If you have any question, answer, or any comment, please let me know.
Thank you, sir. Thank you.